Nope.
stressful day at work. All you
Hello, Sarah.
Hello.
Hi,
Hello.
I'm Dr. John Bennett.
Hello. Nice to meet you, Dr. John.
Yeah, you are presenting, correct?
Yeah.
Do you know how to screen share and everything?
No?
No, do you know how?
Yeah, I know.
Oh, okay. Okay. No problem. Any questions at all?
No?
Okay.
Everything is good.
So you've done these before, huh?
Yeah.
Oh, you have? In Iraq, you've done them before?
No?
Oh, this is your first one?
Yeah, it's the first time to present on the Neurosurgical TV.
Oh my God, to an international audience.
Yeah.
And now Fatima's here too.
Yeah.
Hi, John. How are you?
How are you doing?
Fine.
Okay, we start in a few minutes,
Yes.
and we'll get more people as we go along.
Okay.
But it's being televised in the usual places. You've probably seen somewhere, right?
Yeah.
Yeah, they're all over the place.
Hello, everyone.
Maybe it's too many, but to people that like it, there can never be too many. It's very early for you guys, huh? You just get up, right?
We actually didn't sleep yet, so it's okay.
6 o'clock, really? Okay, well, okay. Yeah, I remember those. I still do that here because a lot of times we have conferences from India, which are night times here. So I stay up all night to televise them, but it does throw your body chemistry out of whack.
Yes.
It's so early here. It's 6 a.m. All
Right.
are sleeping.
Yeah, I know. At 10 o'clock, people here are going to sleep now. It's a funny world. Samar, I'm still waiting on Samar. We don't have to start exactly on time.
It's okay.
Yeah, that's okay.
Mm.
Any panelists want to identify themselves? Most of the time they don't want to. They want to stay quiet, which is fine. It's no problem. Because I can remember being in school wanting to hide from everybody. So they wouldn't call on me. So what year student are you, Sarah?
What?
Are you first year, second year, third year?
I'm in third year.
First
Medical
year?
student. Yeah, third year.
Oh, third year. Okay.
Yeah, third year.
Okay. How about you, Fatima?
The same year.
Okay.
We are the same age also.
Oh, okay.
Yeah.
Okay. So you staying together after graduation also?
Maybe. Why not?
Maybe. Don't know yet.
So do you attend classes now, or is COVID make you stay home?
We are staying
Staying
home,
home.
actually.
Absolutely.
Oh, we have to stay home.
Yeah.
Every part of the world is different, but that's generally the story.
Yeah.
Yeah. In Miami, it's not too tight, but certainly I don't see as many people on the street as I used to. Certainly. Here's Samar now.
Oh.
Now you got to behave. Those are quite good drawings that someone made.
Yes.
Who did that?
My friend, she drew it for me.
Oh, it was very good.
Yeah, she's
I
very
hope
talented.
I hope she does it in the future. She's very good.
Yes.
What happened? Sam, are you there? Keeps falling off. Must be the connection.
Yes.
Okay. I got to put my camera on. Okay. Couple later out. Sam, are you there? No great hurry. He was in though, but he fell out. Now I gotta change my screen. No, it's not neuroanatomy. No. Okay, that's it. Samara's back. Welcome everybody. We start in about, well, as soon as Samara gets here, actually.
Yes, hi John.
Hey, Samara, how you doing?
I'm okay. How are you?
Good, good. Okay.
Is it good?
It sounds like your connection's not too good, Samara. You know, there can be a plan B. I can introduce the speakers. Who is supposed to be first?
I'll start.
Fatima first.
Oh, there you go. You're here. Okay. Okay, Samar, I'll just introduce you and you basically run the show.
Okay.
Okay, you introduce Sarah and Fatima and you handle, if you're going to have questions, you know how to do it. Okay, ready to start?
Yes, I know.
Okay, here we go. 10,
I
9,
hope
10,
okay.
9, 8, 7, 6, 5, 4, 3. Well, let me get my spotlight off. Hold on. Okay. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good evening from Miami Beach, home of Neurosurgical TV. We are graced with the presence of the Iraq Neurosurgery Grand Rounds, headed by Samar Hose, noted educator, budding educator, and neurosurgeon with I believe, a heavy interest in vascular in neurosurgery in Iraq. He formed this group a couple of years ago. He could probably tell you a little bit about it, but welcome. I'll let Samar run the show. Welcome, Samar. You got to unmute, Samar. Unmute. Unmute. I think he may be frozen. Oh, he fell off. Well, I guess I'll introduce Sarah. Sarah is a med student, and she can tell a little bit about herself before she starts her introduction. Greetings, Sarah.
Hi, Hi everyone, my name is Sarah Farah and I'm a medical student from Baghdad University College of Medicine and I'm interested in plastic surgery. Hi everyone.
Yes, okay. Can you explain the title of your presentation, etc.?
Yeah, but it's not the first. My colleague, it's the first presenter.
Oh, okay.
So,
We
yeah,
always get everything exactly wrong.
okay, yeah.
Okay, okay. I was mistaken there because we had some internet problems with Samar, who will be back shortly. But we'll let Fatima take over. Welcome, Fatima. Could you introduce yourself and explain your title, etc.?
Welcome. Hi, everyone. I am Fatma Uday Ahmed, a medical student from Baghdad, Iraq. I'm really interested in neurosurgery as a future career. And today we are presenting the flaps from a neurosurgical and plastic surgery perspectives. I'll start, then my colleague will take over me.
Okay.
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 We will wait, Dr. Samar.
No, I think we can start because seems to have serious problems.
Okay, so I'll start share screen.
Okay.
Yes. So my
Yeah.
present.
Perfect.
I'll start now.
Perfect.
Okay.
Yes.
Okay. As I said, my presentation will be on the scalp flaps from the neurosurgical perspective. My presentation will be a rapid review on the scalp anatomy and the most common approaches in neurosurgery. The scalp region started anteriorly with the anterior hairline, then goes posteriorly to the superior nuchal line, and then laterally to the posterior part of the zygomatic arch. The superior region started anteriorly by the union of the zygomatic process of the frontal bone and the frontal process of the zygomatic bone, then will goes superiorly and laterally along the superior temporal line and will bounded inferiorly by the zygomatic arch. The scalp the scalp consists of 5 layers, and the scalp, the word itself will it's actually a mnemonic for its structure. The first layer is the skin, S skin, and C for connective tissue or subcutaneous tissue. The A eponeurotic and muscle layer, or called the Gallia eponeurotica. The L loose areolar tissue. The P pericranium. The skin of the scalp is one of the most thickest skin in the body. The thickest area at the occiput and the thinnest area at the vertex. The second layer is the subcutaneous tissue. It's a fibro-fatty, dense vascular layer. It is a fibro because it's contained this fibrous septa that interposed by fat, and this fibrous septa will firmly connect the skin above to the gallia below. These 3 layers together will form the scalp proper. It's a 4 to 7 millimeter, so it's a dense layer, and it's a highly vascular layer, so it's contained the major arterial supply and the main arterial supply of the scalp. The third layer, it's the Gallia eponeurotica. It's the intermediate part between the occipitalis muscle and the frontalis muscle. It's a thin and it's inelastic, and that's because the tension that's applied by the occipitalis muscle. These muscles are supplied by the facial nerve. The loose areolar tissue, it's a thin and relatively avascular layer. It enables the sliding of the gallia over the pericranium. The pericranium is the deepest layer, and it's removable except for the area above the sutures. The temporal layer has a different arrangement from the scalp. It consists of skin and also skin and subcutaneous tissue. And we have the temporoparietal fascia, which is the continuation or the lateral extension of the galea epineurotica in the scalp. This temporoparietal fascia, it's on the same level of these auricular muscles, which also supplied also by the facial nerve. The importance of this temporoparietal fascia that's contain one of the major arterial supply of the scalp, which is the superficial temporal artery. From deep to superficial, the temple layers start pericranium, then the temporalis muscle, which is supplied by the mandibular division of the trigeminal. It's directly adhered to the bone, then the temporalis fascia, then the loose areolar tissue, then our temporoparietal fascia. And this temporoparietal fascia will continue as the superficial musculoaponeurotic system of the face. 2 centimeters above the zygomatic arch, the temporal fascia will divide into a superficial temporal fascia and a deep temporal fascia. The superficial fat pad, superficial temporal fat pad will interpose between them, and the deep fat pad will be found deeper to the deep temporal fascia. The blood supply scalp comes from 2 main sources. The internal carotid artery through the ophthalmic gives us the supratrochlear artery and the supraorbital artery. The other main source is the external carotid artery with the terminal branch, which is the superficial temporal artery with its frontal and parietal branches, and the preterminal branch, which is the posterior auricular artery and the occipital artery. From internal carotid, let's start with the supratrochlear artery. It's a small artery, 1 finger breadth away from the midline. It supplies small area of the forehead. Then the supraorbital artery, it's a 3 centimeter away to the midline, and it supply the area till the vertex. In the lateral region, we have the terminal branch of the external carotid, which is the superficial temporal artery (STA), will supply this lateral area and extend to the surrounding area. The preterminal branch of the external carotid, the posterior auricular artery, will supply a small area behind the ear. And lastly, the large occipital artery will supply the posterior part till the vertex. The veins of the scalp, or actually the superficial veins of the scalp, have the same branches of the artery. So the supraorbital vein and the supratrochlear vein will drain in the angular vein that with the defacial vein will form the facial vein. The same superficial temporal vein with the frontal and parietal tributaries. This superficial temporal vein with the maxillary vein will drain or will form the retromandibular vein that have an anterior division that with the facial vein will form the common facial vein, and this common facial vein will eventually drain in the internal jugular vein. The posterior division of the retromandibular with the posterior auricular vein both will drain into the external jugular vein. Lastly, for the occipital vein, will drain into a deep cervical venous plexus. And regarding the deep, there is more details, but however, it's not our point of focusing here. As the final destination of the venous drainage of the head of the scalp, it will illustrated in this W arrangement. the retromandibular vein with its anterior division that will, with the facial vein, will form the common facial vein, then will drain into the internal jugular vein. The posterior division with the posterior auricular vein that both will drain in the external jugular vein. The nerve supply of the scalp also comes from two main sources. Anterior to the vertex was supplied by the cranial nerve, more specifically the trigeminal nerve, and posterior to the vertex was supplied by the cervical spinal nerves. And the anterior area supplied by the supratrochlear and the supraorbital nerves from the ophthalmic division of the trigeminal nerve. A bit laterally was supplied by the zygomaticotemporal nerves, branches from the maxillary division of the trigeminal nerve. And the lateral region was supplied by the auriculotemporal nerve from a branch from the mandibular division of the trigeminal nerve. The posterior area was supplied by the cervical nerves. We have the greater occipital and the lesser occipital from C2 spinal nerves, and the third occipital from the third cervical, and the great auricular from both C2 and C3. Before ending the basic anatomy, let's let's discuss the neurovascular pedicles in the scalp. The supraorbital pedicle and the supraorbital pedicle and the medial frontal pedicle in the anterior group. We have the temporal and the mastoid pedicles in the lateral group and the occipital pedicle in the occipital region. In general, the approaches in neurosurgery are classified into supratentorial and infratentorial approaches, according to this anatomical structures called the tentorium cerebelli. And also we have a combined approaches, and each one of these approaches has many approaches under many approaches subcategorized under it. For the common approaches in neurosurgery, we will discuss the trional approach, the frontal with its supraorbital and the unilateral bicoronal and bicoronal types, the temporal approach, the occipital approach, and the midline suboccipital. The trional approach is the most common approach we use in neurosurgery. We make a curvilinear incision 1 centimeter anterior to tragus, then run posterior to the hairline, then will to end at the widow's peak. The critical structure is the superficial temporal artery and the temporal branch of the facial nerve. So as I said, 1 centimeter anterior to tragus. So 1 centimeter, not less, to preserve the superficial temporal artery posteriorly, and 1 centimeter, not 2, to preserve the temporal branch of the facial nerve. The vascular pedicles contain the superficial temporal artery and the supraorbital and the supratrochlear arteries. Indication for this approach, anterior circulation aneurysm and the paracellular lesion. The supraorbital approach, a slightly curved incision started at the supraorbital notch and then goes laterally in the Burroughs line. The critical structure are the supraorbital artery and nerve, and also the temporal branch of the facial nerve. The indication, this is a minimal invasive approach. So it's used for some anterior circulation, aneurysm, and paracellular lesion. Unilateral and bicoronal approaches, we can do 2 incision, the unilateral frontotemporal which start the same starting point as the trional, 1 centimeter anterior to the tragus, then curve a bit posterior to the coronal suture, then to end 2 centimeter at the contralateral side behind the hairline. The bicoronal, the same starting point, ipsilateral to end to the contralateral point. The critical structure here follow the same principles of the trional because the same starting point. The vascular pedicle contain the superficial temporal artery and bilateral arteries for the bicoronal approach, and also the supraorbital and supratrochlear and the frontotemporal in the unilateral frontotemporal approach, and the bilateral arteries for the bicoronal approach. The frontal region lesions is an indication, one of the indication for this approach. The temporal approach, also we can do a question mark incision or linear incision. The question mark, same starting point, then we'll curve posteriorly at the level above, vertical to the pinna of the ear, then we'll end at the superior temporal line. Linear incision, same starting, and the same superior temporal line. The critical structure here follow the same principles of the trional. The vascular pedicle contain the superficial temporal artery. Indication of the one of the indication is the temporal lobectomy used in epilepsy surgeries. The occipital approach, also we can do 2 incision. We can do the horseshoe incision starting from the anion, then we will curve the progressively to the posterior to end at the mastoid. Or we can do an alternative linear incision. The critical structure are the occipital artery and the greater occipital nerve, which is the same structure of the vascular pedicle. The occipital region tumors is one of the is an example for the indication of this approach. And lastly, the midline suboccipital approach. Usually we started at the C2 vertebrae and goes superiorly to the external occipital protuberance. Posterior fossa tumors and posterior circulation aneurysm are the indication for this approach. And I finished my presentation. Thank you so much for your time. I present a general review of the scalp of the flaps in the neurosurgical perspective. We discussed the anatomy and the common approaches in the neurosurgery. Now my friend will proceed with her perspective, and we will take the question after she finish. Thank you.
Okay, excellent. Fatima, thank you very much.
Thank you.
That's very good for medical students level. Okay, let's see. Samar, are you back in yet? I'm not sure if he is or not. Okay, he continues to have. Okay, we'll go on to the next presentation with Sarah. Go ahead, Sarah. Introduce yourself. Oh, Samar's back. Go ahead, Samar.
Hi, John. Hi, everybody. Do you have me now?
Yes.
Yes, ma'am.
You okay, Samar? Oh, he fell off again. Okay, let's proceed, Sarah.
Yeah, I will share screen.
Okay, introduce yourself and everything.
Yeah, no.
That comes later, right?
Go on. Hi everyone, my name is Sarah and I'm a medical student from Baghdad, Iraq, from the University of Baghdad College of Medicine, and I'm highly interested in plastic surgery. Today I will talk about scalp flaps from plastic surgery perspective. Now screen sharing. Yeah. Yeah,
Perfect.
scalp flaps.
Perfect.
Today we talk about scalp flaps from plastic surgery perspective. Let's start. My presentation will divide into two parts. In the first part, I will talk about flaps and the classification of flaps in general. The second part will talk about a reconstruction of scalp flaps and discuss the most accurate flaps options in each region according to the defect size of that region. Let's start with the first flaps. What is a flap? A flap is a unit of tissue that maintains its own blood supply while being transferred from its donor side to the recipient side. For example, here we have a jury flap. The donor side for that flap is the temporoparieto-occipital regions. The arteries included in it, it's the posterior branch of superficial temporal artery and the occipital artery, while the recipient side for it is the anterior hairline, so that the flaps here used to reconstruct the anterior hairline and to correction some male pattern of baldness. Now, flaps are classified according to three important principles. It's vascularity, tissue composition, and method of movement. According to vascularity, there is 5 important types of flaps. It's random, axial, island, perforator, and neurocutaneous flaps. Tissue composition also have 4 important flaps types. It's the facial and faciocutaneous flap, muscle and myocutaneous flap, visceral flap, and composite flaps. While the method of movement divided into 3 types of flaps. The first one is the local flap that divide into advancement flap, rotation flap, transposition flap. The second type is the regional flap, and the last one is the free flap. Now, the second part of the presentation is scalp reconstruction by flaps. Start with the goals: tension-free closure of defect, maintenance of motor and sensory function when possible, maintenance of contouring, and a protection of the cranium, dura, and the brain. So the question here is, how do I choose the right one? I mean flaps, and does it differ with different location? To answer these two questions, we'll classify the scalp flaps according to location and defect size. In location, there is 4 important regions. It's the anterior or frontal region, parietal region, vertex region, and the occipital region. The defect size divided into small, moderate, and large one. Now, a quick review for the scalp regions. Start with the frontal region, as we saw here with the green color, and this patient with the moderate frontal defect. The second one is the parietal region that included with the temporal region, as we saw here. And the third one is the vertex region. The last one is the occipital region, the patient with a large occipital defect. Now, flaps options. There are many flaps options. For that reason, we'll talk about the most accurate flaps options in each region according to the defect size in that region and some important principles that must take into consideration when dealing with that flaps in the specific regions. So we'll start with the first region. It's the frontal region. For the small defect, we have three options. It's the primary closure after undermining the surrounding tissue, advancement flap, in that case used to lowering the anterior hairline, and the third option is the small rotation flap. For the moderate defect, can reconstruct it with the VY flaps technique. It's a subcutaneous bipedical rotation advancement flap. The second option here is the temporoparieto-occipital flaps, as we mentioned above, that it's used to reconstruct the anterior hairline and correction some pattern of baldness. For the large defect, can reconstruct with the temporoparieto-occipital flaps and the large rotation advancement flap. For that flaps, we need for the incision usually need to be 4 to 6 times of the defect, and we need for the skin grafting to the donor side. The third option is the tissue expansion technique, tissue that's used when the defect size is as much as 50%. A highly aesthetic result can be obtained by this technique, but it's not preferred in many patients because it's two-stage procedure. Now, to reconstruct that large frontal defect, we use something that called large bipedical flaps. And that flaps need to include the arteries from two opposing sides. So the arteries included in it, it's the superficial temporal artery from each side, and the pattern of movement here, it's called packed handle movement, and we need for skin grafting to the donor side. Now, the surgical piers, it's very important to preserve the anterior hairline and approach symmetry when dealing with the frontal flaps. Now, the second region, parietal region, starts with the small defect. The options of flaps, it's primary closure, rotation flap, VY flaps, and rhomboid flap. Rhomboid flap used for temporal sideburn reconstruction. Now, for the moderate defect, the flaps option is rotation advancement flaps, pile loop flaps, and also can use S-shape flap. For the large defect, the options is tissue expansion, it's two-stage procedure. The second option is large bipedical fronto-occipital flaps, and that flaps also you need to require to include the arteries from two opposing sides. So the artery that included from the posterior or occipital region is the occipital artery, and the artery included from the frontal region is the supraorbital or supratrochlear artery. And we need for skin grafting to the donor side. Now, the surgical piers. This region is highly, it's characterized by highly scalp mobility, so it's amenable to local tissue rearrangement, and it's important to avoid the sideburn displacement from aesthetically perspective. Now, small quiz. What is the flap option for the defect? You can take your time to think about the appropriate answer. So, yeah, the right answer is the rotation advancement flap, as we saw here in that picture. Now, the occipital region, the third region is the occipital region. It starts with the small defect that it's easily reconstructed by the primary closure after undermining the surrounding tissue. For the moderate defect that can reconstruct with the rotation advancement flaps and the arteries included in it, it's the occipital artery. For the large defect, can reconstruct with the large rotations flaps that called artichochia flaps, the name of The Miguel Articoquia, the professor of plastic surgery, that's a flap is a 3-flap technique that improves the vascularity compared with the 4-flap technique. So it's classically described to reconstruct the large occipital defect. Now the surgical periods. The occipital region is a moderate scalp characterized by moderate scalp mobility, so it's amenable for the local tissue transfer, and it's important to preserve the occipital hairline. Now, the last region, the vertex region, starts with the small defect. The options is a primary closure, pinwheel flap, and the rhomboid flap. For the moderate defect, can reconstruct with the pinwheel and rhomboid flaps, double opposing rotation advancement flap, or S-shaped flap, that used to reconstruct the circular, moderate circular scalp defect for more than one region. The third option is rotation advancement from the occiput. For the large defect, we can reconstruct it with the large rotation flaps. In that flaps, we need for almost completely scalp undermining, gully scoring, and also need for skin grafting to the donor site. The second option is the tissue expansion, and best aesthetically result can be obtained. Now, the near total defects, when the defect is more than 50%, can reconstruct it with a free tissue transfer. The most used tissue is the latissimus dorsi muscle, rectus abdominis muscle, and the anterolateral thigh. The second option is the serial tissue expansion, and the third one is dermal regeneration template. It's a type of a biomaterial that's used to reconstruct it. It's composed of collagen lats that covered with a thin silastic sheet. Now, the other small quiz. What is the flap option for defect? Also, you can take your time to think about the appropriate answer. Yeah, the answer is S-shaped flaps, as we saw here in that picture. Now, a summary. As a summary for flaps according to the location and defect size. For a small scalp defect for all regions, primary closure is the first options. For the moderate scalp defects, if it's a frontal region, we can use VUI flaps and temporoparietal flaps. If it's other regions, the rotation advancement flap is the best choice. For the large scalp defect, there are different options of flaps according to the region. So if it's a frontal region, the flaps option is temporoparietal orbital, occipital flaps, rotation advancement, and tissue expansion. If it's parietal region, the option is tissue expansion, bipedical fronto-occipital flaps, while the rotation flap is the best choice for the occipital region, and in the vertex region, the flaps option is rotation and tissue expansion. Now it's important to take into your consideration that use adjacent scalp for reconstruction if possible, and incorporate at least one main named scalp vessel in the flaps. The reference for more information. And lastly, thank you, and thank you for your times.
Okay, very good. Samar, are you online?
Hi,
Yeah.
John.
Go ahead.
Do you hear me?
Go ahead, Samar.
Okay. Hi.
Okay. I guess we're continuing to have problems. But Sarah,
Yes.
okay,
there's
go ahead. Go ahead, Samar.
Actually, I want to thank you for giving this opportunity to our medical student, and I would thank Fatma and Sarah for this rapid overview about these topics. And these two presentations are part of our new project, combining the experience of neurosurgery and plastic surgery regarding scalp anatomy and scalp surgery. That's our idea, and I think within a few days, both of these students will present another presentation, but in an advanced level about scalp flap from different perspectives.
Excellent. Do you want to take questions, Samar?
Yes, we are ready to have a few questions, and if it's for me or Fatima or Sarah,
Okay.
that would be nice.
Yeah, I just have a question. Samar, as a general neurosurgeon, I guess you must have to do a lot of your own plastic work, right? Or do you kind of have to learn it on the go on the fly? Or do you consult a plastic surgeon every time you need an extensive revision or whatever?
It's according to the lesion
Okay.
and according to situation in general. If there is scalp defects, large scalp defects, we want to consult a plastic surgery and ask about your opinion and further management. But what we are trying to do here is
Yeah, I'll just finish what I think his thought is. Trying to establish. Go ahead, Samar.
yes, and what we are trying here is to uh, find the principle that this plastic surgery use while dealing with with the scalp in general and different flaps and vascularity, nerve supply, and also we are trying to apply these general rules from the plastic surgery perspective on our specific flaps. This may made new flaps or may made better apprehension of our already used flaps.
Hmm. Okay. Harshad, do you have any questions or comments for either Samar or Sarah and Fatima?
It's an excellent presentation, John. Sarah has presented very well and very nice. And I'll tell you one thing: we are doing all this head injuries since many years, and every time we always involve plastic surgeon. They are the better people to help us out rather than we doing free flaps and all. Whenever you can do a rotation flap, but there is a defect which remains there, and for that we need a graft to be taken, whether we need a vascular graft, pedicle graft, or a free graft. And I personally feel we should involve plastic surgeons who are better than us to reconstruct the scalp. Skull, yes, we are very good in reconstructing. We have got a lot of materials nowadays available right from your own patient's own skull to various materials and the metallic materials. But for a scalp, I would always take help of a good plastic reconstructive surgeon.
Okay. Thank you.
Nice presentation, John. Good.
Thank you.
Okay. Thank you.
I,
Thank you so
I
much.
agree.
Okay, Samar.
I agree with Dr. Harshad opinion. It's exactly combining idea and doing a teamwork is the better to find solution. And what we are doing now is uh, we're trying to revise the topic at the basic level. That's the idea.
Excellent.
Do you foresee a subspecialty in this area of plastic neurosurgery? A fellowship or whatever, or no? You don't foresee that.
Um, hmm. I don't know exactly. Maybe there is something similar somewhere or another, but
Okay.
in a specific, uh, actually, even while we are reviewing the topic, we don't find the principle of scalp flap from this perspective, even as a chapter in our books, it's always a general one, not a specific.
Right.
I think that's give us the idea. What let's give an overview of the topic. Let's combine the already known facts that Sarah and Fatima presents. They are already known facts. What we are doing to make a summary and overview, and let's find a few direction, hopefully in the future.
Okay. Excellent. Excellent. So next week there's similar presentations.
We hope so. It depends, and we are already preparing something, but we'll contact you for the exact time.
Okay. Okay. Very good.
Okay.
Okay. Sarah, any parting words? Or Fatima?
I just
Oh.
want to say that thank you for everyone that saw me, and thank you for you, Sir John.
Yeah. Thanks for the time. That was a great presentation. How, Fatima?
Thank you, John. Thank you for time, and thank you, Ami, for this. Thank you, Dr. House, for this opportunity.
Okay, you both did a great job. Great
Thank
job.
you.
Hey,
Okay.
John,
Yes.
Dr. Saleh here.
No,
Can
no,
I share
excellent.
one?
Yeah. Hi, Dr.
Yeah,
Saleh.
yeah. Hi, how are you? Yeah.
Welcome.
Actually, I'm Dr. Saleh from Bangladesh. So this is one of my patient, this young patient. Can you see that?
Yeah, you don't mind,
picture?
Samar, right? That's
Yes,
fine.
yes,
Go ahead.
sure.
Go ahead.
Yeah, yeah. So this 30 plus years old gentleman who had some parapulse and meningioma initially operated within few months, the thing recurred, and he underwent 3 consecutive surgery. At last, I got the patient on the 4th time. When I found him, he is having the recurrence of intracranial as well as you see the scalp lesions. So I took my plastic surgeon colleague regarding the scalp management because he has skull as well as scalp deficit after the surgery. Unfortunately, 1.5 months of the surgery, we did the surgery, removed the tumor. It came as anaplastic meningioma, atypical meningioma grade 3. So again, the repeated scan shows I couldn't share it. There is some recurrence in the scalp, small nodule-like lesion. So this is a big challenge. I talked with the radiation oncologist colleague that how can they can help us, whether they will go for the oncological management or will go again. So this type of scalp problem, what do you think, your experience regarding removing this lesion and reconstruction, this scalp?
Go ahead,
Mm,
Samar.
I don't see the whole case, but
Oh, okay.
I get an idea about how difficult it is. The answer I don't know, because I think yes, it require a team discussion about the clinical stage of the patient and the possibilities available. And that's why I don't think that
Patient is neurologically intact.
I know. No, it's about the what's the patient let's say demographics and current status and expectation. That's the idea because you are dealing with patient expectations. And I think if you send me the case in a
Yes.
private, yes, I will make it more professional opinion and send back to you.
Okay.
Okay,
That will be good option.
Or do
it's
you
my
want?
pleasure.
Okay.
Thank you very much.
Thank you.
Thanks, John.
Yeah, if you want to leave your email in the chat, what's the best way to hook you guys up? Do you have each other's email, Samar?
I
No,
can share.
I will post my email.
Okay, Samar's going to post it. You can see the chat, right?
Yes.
Okay, just post it in the chat there, Samar. I think he'll get it.
Okay.
I just posted it directly to my my email.
Oh, there you go. I see Samar. You see Samar's?
Yeah, I could see.
Okay.
Thank you.
Okay.
Okay, with a pleasure. Thank you.
Okay.
Okay. Very
Nice
good.
to meet you.
Okay, anyone else have something to contribute? That was excellent, Dr. Select. That's great to do that, to spread learning like this. Anybody else?
I
Go ahead.
think we can give it as an example of the next presentation also. The final product of our discussion with Dr. Salik, we may put it as an example in the next presentation. That will be good
Yes.
as feedback. Yes.
That would be great. Does that sound good, Dr. Salik?
Yes, yes. I think I will prepare the case as per the requirement, and we'll project this one as a case, problem-based case next session.
Okay.
Fine.
That's nice.
Okay, excellent.
Thank you.
Okay, everyone. Thank you very much, Samer, and to both presenters. And we're going to see you next week. We'll let you know the program when Samer has it put together. So thank you very much, and we'll see you next week.
Thank you.
Thank
Bye
you.
bye.
Okay, you can off being recorded. So yeah, those are great presentations. You know, I think a lot of neurosurgery residents kind of need to be brushed up on that stuff, right, Samer? Well, maybe not. I guess we may have lost them. You know, I have a question. Sarah, what was that platform you were using? Like it's a PowerPoint presentation where the text moves and it's kind of like a dynamic. What is that? That's very effective.
Yeah, I can't hear you. Can you repeat?
Yeah, what platform did you use? WordPress to make the presentation because it was dynamic. You know, the text was moving.
Yeah.
Yeah. How was that done?
By the PowerPoint program.
It's a program in PowerPoint where the text moves. The moves.
Yeah. With the animation, we have many choices, and it's that we can added the animations for the pictures and for the sentences, and there are many options for it, floating and other.
Can you show us now?
Yeah, sure.
Oh, this is turning into a IT session.
Oh, yeah. We will back and.
Did you like that, Dr. Salik? You saw her presentation.
Yeah. I don't doing this share screen. I will do it.
Okay.
Yeah.
Yeah, this is very informal.
Yeah. We will do that.
Okay.
Do that. Now here from the insert.
Yeah, I like that. That's beautiful. The way you have that text moves.
Yeah. Thank you.
How'd you do
that? Now I will remove it. I will remove it firstly, and I will show you how I do it.
Okay.
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 So now from here, that's the playlist. There are animations here.
Oh, okay. Oh, okay.
That's animations here.
Yeah.
The choices of animation.
Right.
That. Now I will remove the last one. That.
Right.
That's the number 9 and number 8 of that. I will remove it. And now I will select that and then go to the animation and select what I want. I float on.
Oh, wow.
Yeah, that's and have many options here. Can use that.
Oh, so you just play with it and see what you like.
Or this.
Okay, yeah, that's great.
No, yeah.
Very effective, very effective.
Thank you so much.
No, don't you think so? It's effective. Did you the first time you've done it, or you've done it before?
Yeah, the first time I do it, but the Dr. Samer, who was informed me about all that things. I appreciate how he teaching me all that techniques in the presentation or in the informations. It's guide me. Actually, I very appreciate what he do for me.
Wow.
Yeah.
Wow. Yeah, that's you know, we have an illustrator, we have an animator. I don't know if you've seen her. Her name is Waralex. She's a neurosurgeon from Thailand. She's a very good illustrator. And I'm going to show her this. I don't know if she knows about it, but this would be a tool she could use. Another tool, you know, that's artistic, that makes the presentation, you know, more, I think, more effective.
Yeah. Yeah.
I think visually more effective.
Thank you. Thank you.
Yeah, I
so
think
much.
I'm going to show her that. I think she will definitely like that. And who did the artwork? You said a friend of someone's did the artwork.
What?
Someone who did the artwork for the banners.
If you mean, I'm really interested in the plastic surgery, and there, Dr. Samer, who's with the neurosurgeon, actually, for that, we do a combination between the two specialists, and that's what doing. Yeah.
Oh, okay, very good. Okay, then. So I guess we'll see you guys next week. Where's the other presenter? Let me get view options. Let me get you off there first. Stop your screen share.
Thank you, John, for your time.
Thank
Yeah,
you.
yeah. Okay, Fatima. Okay, thanks for your efforts.
Thank you.
Okay, and we'll see you next week.
Thank you, Dr. John. I'm very interested to meet you.
Oh,
I'm
nice to
so
meet you
happy
too.
to meet you.
Okay,
Nice
we're
to meet
gonna edit those. They'll be ready in and you know what we're gonna do with Samer, because this is television. This is what we're gonna do. Get Samer, and we're gonna do a video of the introduction to this.
you. Yeah.
And then we're just gonna put it there in front. You know, so when he's got a good connection, we'll put a good introduction, so it'll look
Thank
almost professional.
Thank you. Thank you so much.
Okay, everyone. Thank you, Dr.
Bye-bye.
Select, for your contribution.